Sreekanth Vemulapalli and Mike Gibson coming to you live from ACC 2026. And Sreek, you and I are both very, very interested in event adjudication, something that's done by people, experts sitting around. It used to be in the old days, we would have some pizza and Diet Coke, and we'd do this by consensus, but now we do a lot of it electronically. But the next step, the next evolution is to have AI do it. So you did a study on this. What did you find?
Yeah, thanks, Mike. So what we did was we trained an algorithm using real clinical trial adjudication data. And then we took it and we said, look, can we apply it to a different trial? Same endpoints with new definitions, and then some new endpoints that it hadn't seen before. How well would it work to do that? And we did this in a couple different ways. We used the algorithm itself. Then we did a hybrid approach where we said, look, when the algorithm is uncertain, then go ahead and have the humans do it.
And
And
Sreek, that's a
yep.
big issue. I'm trying to do this kind of stuff too. How do you know when it's uncertain?
Yeah,
Right.
so the we've trained the algorithm basically to do a few things. One is it uses an LLM or a large language model to produce a summary of the event dossier. So the event dossier is all the stuff in there that the site sends you to tell you whether an event occurred or not. And it produces a summary, which is important because you can then audit that and say, oh yeah, this meets the definition or this doesn't based on the summary. And then we train a model, an AI model off of that to say, is this in fact an event? And what comes back is a probability. 80% chance this is the event, 50% chance, 30% chance. And then you can set the threshold and say anything, 80 or 90% or greater, we're going to call that an event. And less than that, we're going to say no event. And what we did with this hybrid approach is we said, if you're in that 30% uncertainty, send it to a human. And let the human decide. And everything you're more certain about, then call an event or call it not an event. And then we actually even compared that to just using GPT-4. So that's your chat GPT and said, what's better? Our algorithm, our hybrid approach, or GPT-4. And it probably won't surprise you, Mike, the hybrid approach was the best.
Hmm.
By best, I mean it most closely recreated what human beings did. And we actually took that and said, okay, can we apply that to re-estimating the primary endpoint from a clinical trial? So we used the Euclid trial, which was a trial about 10 years ago of ticagrelor and clopidogrel in patients with peripheral artery disease, had a primary event point of CV death, MI, and stroke. And we said, okay, let's try and reproduce it. And the hybrid approach reproduced the endpoint within the confidence interval of the original hazard ratio. The overall trial result was negative. There's no difference between clopidogrel and ticagrelor, and we were able to reproduce that both with our algorithm alone and with the hybrid approach, both of which were a bit better than just GPT-4 alone.
Really? And when you say you use large language models, were these off-the-shelf ones, or did you create your own kind of programming?
Yeah, this is off the shelf. This was GPT-4 we used just to summarize
Mm-hmm.
the
Mm-hmm.
dossier. And now we have GPT 5.2. So it's
Right.
just an off-the-shelf model. But again, the clear point, important point is all we did was summarize the dossier. We built our own model to do the adjudication.
So it wasn't the Chat GPT model doing the adjudication. You built a separate model to go through that dossier, what the chat had summarized, and then
Yes.
it decided. And what kind of AI modeling was it? Was it a large language model there that was custom built?
It's not a large language model that's custom built, but it's essentially a transformer and encoder model. So similar type of technology, but not as large as a large language model. So this one is built to do adjudications, although it can handle different types of events. So we trained it on MI and stroke, and then we went to MI and stroke in a different trial, Euclid, and then bleeding and cardiovascular death as well. So it hadn't been trained on those things, and we applied it there, and it did quite well.
Really interesting. So this is kind of an agentic AI approach where it takes how it learned something in the past and applies it to a future
That's
problem.
that's exactly right. And we think that's
Mhm.
important because you don't want to have a model just for MACE just for bleeding, just for this, right? You're going to run the next trial, and the next trial is going to have a different definition than the one you just did. You
Right.
want to be able to adapt it and use it for the next thing and not have to retrain a whole model.
Yeah. Well, how often did you have to turn to the human for adjudication?
Yeah, we looked at this. We set different thresholds and said, where does the performance look the best? And so we said, look, when you're in the top 30% of uncertainty, that's when we want you to go to the human. So, but just because it's the top 30% of uncertainty doesn't mean it's 30% of the time. It was actually less than that that we had to go to the human.
I see. So it's interesting. You kind of run it and then you say, you don't decide to send it off to human one at a time. You look at the whole population and you say,
Yep.
these are the 30% where we're the least confident,
Yes.
and then you send it off.
Yep.
Interesting.
Yep.
That's a
Yep.
very interesting way of doing it, rather than saying a threshold of,
That,
say, 30% confidence.
that's right. You could do it that way.
So
But
you look kind of like at the
that's
worst
right.
tertile of confidence, basically,
That,
and sent that off.
that's exactly right, Mike.
Interesting. Well, all right, we still got a job, man.
Well, I just wanted to say, one thing, Mike, which is that we're talking about this in the setting of clinical events adjudication for trials. But let's think for just a second, what if we did this in the EHR
Yeah.
for phase 4, for safety, for figuring out events in your own healthcare system, things that we can't realistically do right now. I think that's where the future for this is.
Well, you know me well, Shreek. You know that I'm all about direct to participant kind of trials moving forward. They're much more affordable. We're going to have to harness, as you just said, the EMR and any other information we collect directly from the patient. Sometimes there can be some upcoding in the EMR
Yeah.
for some events, so it's a little tricky. But I think, you and I are going to be living through a whole radical change in how we do trials. And it's really great to see you leading the charge over on this AI CEC stuff. Great work. And I look forward to learning more.
Thanks, Mike. Enjoyed the conversation.